I think it's useful to have a sense of how these two instruments developed, these screening instruments. So the MMSE was developed in 1975 by a husband-wife team, Marshall and Susan Folstein, as some of you may be aware. And for a long time, this tool was able to be used free of charge. And then in the 2000s, it was Marshall and Susan Folstein sold the tool to Psychological Assessment Resources, PAR. And since then, there's been, as you would imagine, a bit more copyright issues to get through in terms of using the tool. The MoCA was developed in 1996 by a neurologist in Canada, a Lebanese-Canadian neurologist, Zayed Nasreddin. And that tool, the development of that tool, as you can see from the second column here and the last point, it was really developed in conversation with the MMSE. In other words, that tool, the MoCA, was really developed as a screener for mild cognitive impairment for people who had scored on the MMSE as cognitively normal. And both of these are screening tools that are typically used in clinical practice. So we see these tools, for example, used by psychiatrists, and we see them used, particularly the MoCA is more used by GPs. And in the Caribbean, where I'm from, these tools are used quite frequently by psychiatrists because psychiatry is really, for many people who have any type of suspected dementia-related condition or impairment, they tend to enter into the care pathway very, very late. And so they enter when there is an issue that seems to be in need of a psychiatrist's help. For those that are assessed with the MoCA, which is typically what we find in the Caribbean as well, and in some other LMICs where there's a very high prevalence of cardiometabolic disease, so cardiovascular disease, diabetes, renal types of failure. This is what we see in those contexts, used a lot by GPs in clinical practice, because the MoCA tends to be able to identify those cases where there is some type of vascular-related impairment in terms of functioning. The MMSE and the MoCA are both scored out of 30. Both of these are typically used as secondary endpoints in clinical trials.